Good evening, one and all. I am Dr. Sriram, VR Surgeon Arvind, Coimbatore. I'll be presenting on non-neovascular exudative AMD.
Can we have next speaker, Dr. Purna?
The first patient was a 67-year-old female who is a gynecologist by occupation, but 6996 in both the eyes was referred to us to rule out macular degeneration. Both eye fundus revealed a large drusenoid PED. This was the OCT image. Since the patient was asymptomatic and 6996 vision, we had decided to keep the patient under observation and treated conservatively with ARED supplementation and antioxidants. Patient came back to us after 5 months with metamorphopsia more in the left eye, where we could see development of SRF at the apex of the drusenoid PED. On OCTA, with manual segmentation, especially at the RP fit, no evidence of any high flow lesions were noted. With close follow-up at 1 month, we could see worsening of the SRF at the apex of the drusenoid PED in the left eye. Hence, we went ahead with further imaging. On FFA and ICGA, no evidence of any hotspot or no evidence of any neovascular network was noted. Considering the patient being a doctor, we also gave the option of observation and intervention. She wanted to go ahead with intervention in the form of 2 monthly injections of aflibercept. After 2 monthly injections of aflibercept, we couldn't see any significant change in the SRF, which is again suggestive of a non-neovascular exudative collection of fluid. Patient was further was managed conservatively and has been on close follow-up almost once in 3 months, and no significant difference in change in picture of the disease or signs of any neovascularity has been documented. Moving on to the next case, she was a 74-year-old female with 618 in the right eye and 624 in the left eye. Both eye fundus image shows large drusenoid PD. This was a OCT image with large drusenoid PD and SRF at the apex of the drusenoid PD, with areas of sub-RP hyperreflectivity with a suspicion of CNVM. We went ahead with the imaging and no evidence of any hotspot or no evidence of any neovascular network was noted both on FFA and ICGA. Patient has been, OCTA on with manual segmentation confirmed the same findings. The patient has been kept under observation and no significant worsening or development of any neovascular network was noted till date. Moving on to the next case, the patient came to us with right eye 6.6 vision and left eye 6.24. Both eye fundus showed confluent cuticular drusen. OCT showed confluent cuticular drusen with RP undulations with SRF with subretinal hyperreflective vitelliform material. A similar picture in the left eye was also noted with RP atrophy. On manual segmentation on OCTA, especially at the RP fit, no evidence of any high flow lesions were noted. Left eye showed a projection artifact, but no evidence of any documented neovascular network was noted. FFA and ICGA confirmed the same thing except for the lace staining corresponding to the confluent drusen. Since the patient was already had lost vision in the left eye, we went ahead with the trial of anti-VEGF injection of the right eye, but no significant response to injection was noted. Moving on to discussion, non-neovascular age-related macular degeneration with SRF has already been reported, where multiple patterns of SRF associated with the similar condition has been described. Sikorsky came up with the SRF pattern of accumulation in the angular crepe between confluent drusen. Kirkus et al. Explained or documented apex fluid along associated with the drusenoid PD. Leckel et al. Also explained regarding low-lying SRF draping over confluent drusen. So these are the images depicting multiple patterns of SRF which could be associated with this novel subset of non-neovascular exudative AMD, out of which the apex pattern being the most common and most commonly associated with high rates of collapse of the PED and atrophy. So the common mechanism which could be associated is the increased distance between the choriocapillary Brooks complex and the RP and the outer retina, which can lead to RP and photoreceptor dysfunction. The apex of the drusenoid PD represents the greatest separation of the choriocapillaries and most likely location of the RP atrophy. This may explain the most common pattern of apex SRF associated with the drusenoid PD. Another important point which we should bear in the mind while treating these patients is most of them eventually end up into the collapse of drusenoid PD and advanced forms of atrophy in the form of iRORA or CRORA. So the take-home message will be drusenoid PD can develop SRF during its evolution and is a great mimicker of neovascular AMD. Multimodal imaging is mandatory to confirm the presence of neovascular network when SRF is noted. Anti-VEGF may not be injected reflexively without confirming the presence of network using multimodal imaging like FFA, ICG and OCTA. And non-neovascular exudative AMD is a sign of progression of dry AMD, and they eventually end up in atrophy in the form of iRORA and CRORA and rarely neovascular AMD. Thank you.
So these are the situations where not to inject,
Yeah, better not to over-treat them, sir.
because most of them are transurative.
Most of them are transurative and they are not associated with any underlying real neovascular network.
So in these situations, if there is any sign of activity,
Yes, sir. In the form of?
Sriram or hemorrhage,
Yeah, then we'll have to inject. Hemorrhage indicates that it is obvious neovascular network,
so
then
we
we'll
have
have
to
to
watch
go.
very closely
Yes,
for
yes,
these signs of activity.
exactly, sir. And better to document with FFA and ICGA.